beyond menopause. And we thought that we would highlight that, especially as there is a lot of changes that have come in place in terms of our screening and testing. So today we're focusing on HPV, all its manifestations. I know that there was a talk in the faculty on Monday. Maybe some people started with that. The focus of today is much more clinical than biological. And we, for that, we've also prepared some testing, some screening, as well as vaccination outside, as well as mammogram. So those that are willing to participate for your own good, at your own cost when it comes to mammogram and vaccination. But for screening, obviously, that's part and parcel of care. And we will be able to take care of that. So without much ado, I just want to appreciate the audience present here and the ones that will join online. But much more to introduce Dr. Atisha, who's the head of oncology, and she's going to be running the program on our behalf, gynae oncology at Albert Luthuli. Over to you, Atisha. Thanks.
Morning. Thank you, Prof, for the welcome. Welcome to everybody here and those online. Sometimes I feel HPV is the core of my existence. It's something that I deal with every day. I often say it's either my best friend or my worst enemy, depending on how I feel. My best friend because it keeps me busy, my worst enemy because it's something that is so preventable, the disease that it causes, but we see so much of it. And the prevention of the disease lies a lot in ensuring effective vaccination, effective uptake of screening, and effective treatment of those that are found to have the disease. And every year we try and promote this through these platforms by raising awareness both in the academic and medical community, and also when we do outreach to other hospitals, clinics, etc., to promote uptake. We have seen an increase in screening. And what we have noticed in our clinics is, yes, our numbers are still quite high, but the stages at which they're presenting have decreased. We are not seeing that many advanced stage 4 diseases anymore. They're all majority we are finding within the realm of cure, whether it be with surgery or radiation therapy. So we will continue the fight on whatever platform we can. And today we are going to be raising awareness amongst the faculty here. And one of the reasons we wanted to address academic faculty is that a lot of time we feel it's not going to affect me because I am out of that group of low socioeconomic groups. It's not going to happen. But HPV is a very common infection. 9 out of 10 sexually active adults at some point in their lifetime will have this infection. And whether you develop disease or not depends on your ability to clear it. So it depends on your immunity. And today we're going to talk about, firstly, the virus itself, how we're going to boost our immunity, and our screening. So our first speaker for today is Dr. Mould. Most of you are acquainted with him. He's been in the department for many, many years, and he's joined the gynae oncology unit in 2022. He's currently completing his subspecialty training. There's about a month left before I can go on permanent holiday. He will be the person you contact, and he is going to give us an overview of the virus itself and its pathogenesis. Dr. Mould.
All right. Thanks, Dr. Murch, for the introduction. Welcome to everybody. The talks this morning are going to kick off talking about a bit of basic science. And basic science talks have the potential to be quite dry and boring. But we will stick to that which is practical and that has real applicability. So hopefully in the course of this talk, we'll be able to set you up to understand everything else that gets said this morning as we seek to understand the way that HPV itself works. So a little bit of history. Back in 4 BC, I wasn't born then, in case you're wondering. I haven't been in the department that long. The existence of lesions on the cervix was discovered by Hippocrates. He recognized that there were lesions on the cervix which could or could not progress on to cancer. But the idea of what might cause them was unknown at that point. The progress in understanding warts happened a lot earlier than in terms of understanding cancer. And so it was postulated in around 1907 that warts were caused by some kind of a virus. And our friend George Papanicolaou in 1928 then discovered that those changes which Hippocrates had seen on the cervix macroscopically were also visible microscopically. He still didn't know what caused them, but he recognized the transformation of cells that could be picked up on pap smear, and that was the beginning of our journey in terms of preventing cervical cancer. It was only in 1949 that a person by the name of Strauss described the HPV virus itself. He looked at it under the electron microscope. He recognized that it was the cause of warts, but at that point it still wasn't recognized that that was the cause of cervical cancer. And there's only this man here who, in the 1970s, was the pioneer of understanding the fact that HPV caused cervical cancer. And he, in fact, was given the Nobel Prize in 2008 for his work to unpack the viral etiology of cervical cancer. So those are the forefathers that we have to thank for our understanding of HPV and cervical cancer. So we've known about cervical cancer for about 70 years, but cervical cancer is known about us. HPV certainly has known about us for tens of thousands of years. And when we look at the different subtypes of HPV across the globe, we see that those subtypes mimic or correlate with the patterns of human migration back tens of thousands of years, certainly, and possibly hundreds of thousands of years ago, which tells us that HPV has been infecting humans for almost as long as humans have existed. And it's really interesting to see that the subtypes, as we'll see in a minute, across the globe are quite different to each other. And that is a very ancient phenomenon, telling us about the age of HPV. Just a little word on prevalence. So when we think about prevalence when it comes to HPV, as Dr. Mraj mentioned earlier, lifetime prevalence is around 90%, but it's more important to understand point prevalence. So at any given point in time, how many people have HPV? Quite a useful map this. You'll see that the colors there are the incidence of cervical cancer. So the darker the color, the more common cervical cancer is in the country in question. You can see that obviously sub-Saharan Africa is a real hotspot for cervical cancer, as we all know. But the purple dots tell us the rates, the point incidence of, or point prevalence of HPV. And so you can see that it's down around 6.6% in Europe at any given point in time. About 6.6% of women will have high-risk HPV, whereas in Africa it's around 23%. And then it just shows us the different subtypes that are prevalent. And you'll just notice that HPV 16 is the commonest subtype across the world, but that the next commonest is quite variable. So in Europe, it is HPV 18, which is the next commonest high-risk HPV. But across the world, it varies. 52, 31, 58 are the second commonest causes, or not the commonest causes of cancer, but the second most prevalent HPV types. And so in Africa, you can see that the incidence of HPV 16 is roughly double that of the next commonest. And then 52, 58, 18, and 31 are all roughly similar in terms of their incidence prevalence. Having mentioned that, just to say that global prevalence, in other words, lifetime prevalence, is around 60 to 80% of women. And in HIV positive women, that's probably a little bit higher. but it's actually not the lifetime prevalence of HPV with HIV positive women that we worry about. It's the fact that they don't clear infection. And so while their lifetime prevalence is probably roughly similar to other women, their point prevalence is higher because they don't clear the infection. So let's talk a little bit about the family of viruses. Papillomaviruses come in 5 different types. There's alpha, beta, gamma, mu, and nu. And the ones that we're interested in all fall into the alpha papillomavirus family. And that is the genus of alpha papillomavirus. The species of alpha papillomavirus is then divided into 1 to 9 when it comes to the alpha papillomaviruses. And the ones that we're interested in all fall in the types 5, 6, 7, and 9. So if we then drop down there to the actual subtypes, HPV 16, that happens to be in group 9. And then below that, there are sublineages. So not all HPV 16s are the same. Some are actually much more pathogenic than other HPV 16s. And so, for instance, you'll get something like sublineage D2, which is far more infective and far more likely to progress to oncogenesis than another sublineage. Another way of representing that is really to say that there are around 200 types of papillomaviruses. You'll see around the outside edge, I don't have a pointer, but there's at the bottom gamma, beta, on the right-hand side, your alpha group, and then nu and nu right down at the bottom there. You can see that the alpha group is probably about half of papillomaviruses fall into that group. But it's only those ones in red that are the oncogenic types. So they comprise a tiny proportion of the total number of papillomaviruses. And there's probably around 200 species, and only around 100 of those actually affect humans. The type that cause cutaneous warts are the ones highlighted in blue, and you'll see they fall into the gamma group, and up there, HPV2 in the alpha group. So the family papillomaviruses is very wide. Just to say that papillomaviruses are named after their L1 capsid protein. So the L1 protein is the means by which we identify which type of HPV virus we're talking about. We'll talk a little bit about that later. So if you see a picture of the papillomavirus, this is what it's generally represented as, nice and simple for us gynecologists, nothing fancy here. Basically an outer capsule, which has got an L1 and L2 protein, and then a DNA component. You'll see there's a circular DNA, which is wrapped around histones. That's all you really need to know. So there's an outer capsule, an inner genetic component, and those are really what's going to tell us about the pathogenesis of HPV that we need to know. When we zero down on that genome, you'll see it's a double-stranded DNA virus. You'll see that it's a circular genome. And generally, whenever you see this kind of picture, you want to read it from the 12 o'clock position. So the way this DNA gets read is starting at the 12 o'clock position and progressing clockwise from there. So you'll see on the right-hand side, there's the early proteins, E1, E2, E7, E6. And then on the left-hand side, the late proteins, L1 and L2. The L1 and L2 are responsible for producing that capsid that we saw in the first picture. And the early proteins relate to the genetic function. Looking at it a different way, this is probably the most important picture, and it looks confusing, but let's just try and understand it. E6 and E7 are the oncogenes. These are the things that cause HPV to cause cancer. And we'll talk about how they act in a minute. But it's important to see that before those oncogenes, there's a upstream regulatory region. In other words, before we transcribe the E6 and E7 genes, there's a degree of regulation that goes on. Downstream of the E6 and E7 genes is the E1 and E2 proteins. Those proteins are responsible for autoregulation. So, the pointer, don't have one. Up at the top there, you'll see just next to where it says P97, there's two little dots. Those dots are the point at which the E1 and E2 proteins bind, and they regulate the production of the genome from there. So when E1 and E2 are intact, the production of the genome is regulated, E6 and E7 are not transcribed, and we have a controlled regulation of HPV production. Hope that makes sense. All right. Lots happening in this picture, but I really just want you to see a couple of things. Effectively, you can see our HPV virus entering the cell. And then you can see that in 6 there on the right-hand side, that it forms an episome. The DNA is contained within the cytoplasm of the host cell in its circular form. That episome then uses the host mechanism, the TGN, which is the trans-Golgi network, to actually replicate. So you can see that the host DNA on the left-hand side there is separate, not involved in the process. And you simply have this episomal HPV DNA replicating using the host mechanism. It uses the transcriptases, the RNA mechanisms of the host cell, and it produces more of itself, both the genetic material and the capsid proteins, and it assembles more viruses, completely independent of the host genome. This is something that to my slight embarrassment, only really understood quite recently. I think we've all seen those pictures of the squamous epithelium and how HPV affects the squamous epithelium. And I've always wondered, why does it start at the bottom and not at the top? It's really the HPV virus goes in at the top and then it moves down and eventually goes through the basement membrane to cause cancer. That would be the sensible thing to think. But in fact, it works the other way around. In order for you to get an HPV infection of your squamous epithelium, you need to breach the full thickness of that squamous epithelium, and the HPV virus needs to enter the basal cells. Unless it enters the basal cells, it cannot continue with its life cycle. If it enters somewhere halfway down, the cells are not replicating, and the HPV won't replicate. So it enters the basal cells of the squamous epithelium, and at the base there, the replication rate of HPV is very low. You generally just have a bit of a viral genome at the bottom, no virus particles. Those cells at the base are non-infective. As the cells mature, the HPV replication increases, and eventually you start to produce viral components at the top. And when the epithelial cells are shed, the viral components are shed with the cells, and those are then potentially infective. So there's no side-to-side infection. So the HPV doesn't move from one basal cell to the next basal cell. The movement is always upwards, and the viral particles are shed. Also important to notice that there is no damage to the host cell. The host cell is, under the microscope, completely normal. And that means that the HPV is able to continue its life cycle unhindered. It needs healthy host cells to continue. So this is the normal situation with HPV replication. Now, you would then ask yourself the question, well, then how does HPV cause cancer? If this is the normal situation for HPV, existing as an episome within the host cell, using the host cell's mechanisms of replication, but causing no damage to the host cell. It's important to notice that HPV that's oncogenic and non-oncogenic are exactly the same. They don't differ. There's no different life cycle for HPV 16 as compared to a non-oncogenic HPV. And so the existence of oncogenesis is actually an abnormal phenomenon. It's an aberration that occurs occasionally. All right, so just remember that when it comes to the HPV vaccine, our focus is on the host immune system. We know that for HPV to result in pathology, it needs to be persistent. And that in general, the host immune system clears the HPV and therefore oncogenesis doesn't occur. So when we look at that diagram that I showed you earlier, you can see that the entire life cycle of HPV is within the epithelium. And so there's actually very limited access of the host immune system to the HPV virus. And so it takes quite some time before the host immune system actually responds to the HPV because it has no reason to recognize it or to act against it. So what happens with oncogenic HPV? It's back to those E6 and E7 proteins. They are different in oncogenic HPV as compared to non-oncogenic HPV. Let's say your type 6 and 11 that cause warts versus your type 16 and 18 that cause cancer. E6, it binds and it degrades the P53, protein 53, which is known as the guardian of the genome. So P53 basically is the mechanism by which the cell puts brakes on any kind of abnormality. If a cell becomes abnormal, if there's a mutation within the cell, P53 kicks in, causes apoptosis, the cell dies, and the mutation doesn't go any further. E6 inhibits the action of P53, and you then have the potential for a cell which has mutated to replicate and to become cancer. E7 has much the same effect on retinoblastoma protein. Retinoblastoma protein is responsible for dampening down the E2F transcription factors. And when you get rid of retinoblastoma protein, those E2F transcription factors ramp up in an uncontrolled way, cell goes into S phase, and you get uncontrolled cell proliferation. So basically, E6 stops abnormal cells from being eliminated. E7 promotes rapid replication of genetically abnormal cells. In a low-risk HPV, the E6 binds, but it doesn't degrade P53, and E7 doesn't really even bind to retinoblastoma protein, and so it doesn't have the potential to cause oncogenesis. There's also a few other things. There is a slightly higher propensity for the oncogenic HPVs to integrate themselves into the host genome and some degree of abnormal MRA function, but it's really the main issue relates to E6 and E7. So then how does the actual cancer happen? So we have this oncogenic HPV subtype, which under normal circumstances causes no effects in the cell. It's only when that HPV genome gets integrated into the host genome that we get problems. And that happens accidentally. So it's not the intention of HPV, if we can say a virus has an intention, to integrate itself into the host genome, because that effectively is very bad for its longevity. When it does get integrated into the host genome, it's a dead end. The cell will die, the HPV will die, and you won't get effective viral replication. Now, the problem is really when you happen to get E6 and E7 integrated into the host genome without the regulated proteins. So you can get the whole of the HPV genome integrated into the host DNA. That's not really a problem because your E1 and E2 proteins still cause negative feedback on E6 and E7. But when you just get a fragment of the HPV DNA integrated into the host genome, then you can get uncontrolled replication of E6 and E7, and you can get oncogenesis. Hope that makes sense. It's also actually important where in the host genome it gets integrated. Certain places are more problematic than others. So as I said earlier, viral integration is not the aim of HPV. It's an accidental phenomenon. It was actually interesting when they first developed the HPV vaccines. They used a patient with cervical cancer to generate the vaccine particles, and it didn't work. And that was because the the viral particles produced by an oncogenic cell were actually not normal, and they didn't produce the appropriate immune response. And it was only when they used HPV from an unmutated cell that it actually worked. There is a small percentage of patients who get oncogenesis without HPV integration into the host genome, but I don't think we need to talk about them. Just to say that it is subtype specific, so about in HPV 18, 100% have viral integration. HPV 16, maybe only around 85% have viral integration. So, all of that theory that I gave you, how does it relate to your actual cells that you see on the microscope? Basically, if you have no HPV persistence, you don't get dysplasia. If your HPV is transient, none of this occurs. If you have a persistent HPV replication infection, it means that episomal replication is happening. The normal process of extra DNA replication is happening. But when you look at those cells with episomal replication, most of them look normal under the microscope. When we move to high-grade cell, most of those cells are undergoing episomal replication, but they don't have viral integration. So high-grade cell represents cells which have some degree of alteration, but not necessarily viral integration. And then late in the process, in moving from high cell to invasive cancer, viral integration occurs and oncogenesis kicks off. That's really just explains this picture, which is really, if you look at the circles at the bottom, that's where we want to focus. The dark parts are the rates of non-oncogenic HPV in the population. So if you look at patients who are effectively normal cells, the majority of the HPV subtypes that you're going to find in those patients are actually non-pathogenic. And as we move towards precursor lesions, high-grade cell, you'll see that about 50% of those patients have high-risk HPV subtypes in them. And by the time you move to invasive cancer, you can see that 3/4 have now got HPV 16 and 18 and other high risk, well, 16 and 18 specifically. And so the proportion of oncogenic HPV increases as we move towards invasive cancer. And it makes sense because obviously, when you have an HPV that's non-oncogenic and never causes host cell destruction, it's got a much better chance of survival. And so generally the incidence of low risk HPV in the population is higher. This again is something that I think we need to understand. In our minds, certainly at 6th year level, we're told HPV infection causes in a normal cell, results in low-grade cell, and then that moves on to high-grade cell, and then that moves on to cancer. That's actually not how it works. The solid lines indicate the general movement. Generally, low-risk HPV infection gives you a low-grade cell, and most of those regress back to normal. High-risk HPV can give you a low-grade cell, but it's more likely to give you a high-grade cell. And it's not very common that low-grade cell goes to high-grade cell. They are separate entities. So we don't necessarily see this progression that we think in our minds must have low cell, and then later on you'll get high cell. No, high cell often occurs ab initio with high-risk HPV infection. And again, even with that, the most common outcomes for high-grade cell are either regression or persistence. And only a small percentage, probably around 10%, go on. In fact, it's less than 10% go on to invasion. So I think we just need to reset our minds in terms of how the general pathogenesis works with HPV infection. Last word to set us up for talking about vaccines. Just the HPV and immune detection. As I said earlier, mostly intraepithelial and doesn't raise the eyebrow of the host immune system. But when you do get an immune response to HPV, it can either be a cellular immune response, T cells, or a humoral immune response, B cells. The B cell response, in other words, the antibody response, prevents HPV infection, prevents entry to the cell, and there is quite a long lag time between the viral binding and actually entry to the cell, and that's when the HPV, the anti-HPV antibodies get the opportunity to prevent HPV infection. In the absence of vaccination, it takes about 6 to 12 months for you to get an immune response, a normal immune response to the HPV. And that immune response is generally not a very strong one. Happens in about 60 to 80% of women. And it generally have a result in low titers and rather somewhat ineffective antibody prevention of infection. In terms of controlling HPV, and that really explains to you how the vaccine works, because you realize that if you could get a more effective humoral immune response, you would prevent HPV from integrating itself into the cells. In terms of controlling HPV infection or clearing HPV infection, that's a function of the T cells, and that's why we can understand why HIV is such an issue when it comes to the co-infection of HIV and HPV. CD4 and CD8 cells are really critical to the process of clearance of an existing HPV infection. And interestingly, it's the human leukocyte antigen system is important there, which means that it's actually, there is a host predisposition to persistence. So it's not only what kind of HPV am I dealing with, but actually what does the host genome look like? And so certain HLA types are prone to certain HPV types or sub-lineages. And so that's quite an interesting fact. That explains why not everybody's response to HPV is the same. And then the virus itself actually has the ability to dampen down the host immune T cell response, which is part of its means of evading detection. That's all we have to say about the basic science. Can I take questions? All right, any questions? Either you understood everything or you understood nothing.
Stepwise, walk from, especially with the overproteins, and then we've got many types of things, throw them around, and we actually don't know what where do they add, except that we told you they are not of sensitive, blah, blah, but so apologize that I did go out, but part I thought was just that walk through the pathogenesis, and at one point that one time. And I think that's very important. Because not an oncology vector, because a pathophysiology understanding of where it is.
Thank you. Thanks, Dr. Moll. So next up on our program, I will confess I do not have a presentation. I do have 500 of these. I just didn't want to rehash another one for today. So I decided to go another route to make it more interactive, to involve the audience here. And if you all are really good and able to answer my question, there are rewards. The next topic we're going to discuss is screening for cervical cancer. And there are many screening tests out there, not only for cervical cancer, but also for breast cancer, colon cancer, diabetes. We're going to go non-oncological. So my first question that I would like to know is, what is the definition of a screening test? Anybody can answer and get a reward. Anybody?
Stay behind the mic, raise your mic.
Are there any takers? Yes, sorry.
It's looking for awful.
Okay. Dr. Pandey?
And to finish that, I think it's important that it's in the normal population.
Yes. So screening test is a test that has the ability to detect disease in asymptomatic patients. So in our patients who have HPV infection and early pre-malignant changes, they don't have symptoms. It's only when they actually start developing cancer that they do have symptoms. So next question would be, what screening options do we have for cervical cancer? Any registrars?
So for the screening function that will be the flexible, which identifies the abnormal cells.
Okay. So one is pathological screening. Any other?
HPV
HPV DNA testing, yes.
visual inspection.
Good. Mhm. Good. So, as Dr. Mould in his introduction spoke about George Papanicolaou, the first screening test was your pap smear, where the special stain was developed to look at these pre-malignant lesions and detect which patients would go on. These were usually reported as high-grade or low-grade cytological lesions. The first screening test was extremely effective. It caused a decrease in mortality of cervical cancer by 80%. But we were not satisfied with that, so we went looking for other methods. And the next one we looked at was detection of HPV. And the idea behind that is to find your high-risk HPV before it can cause cytological changes and treat it. Following on to that, something that's a bit more novel, not really available in South Africa, is HPV mRNA testing. So those will tell you which patients who have HPV, it divides them into two groups, one that is most definitely going to develop abnormalities, and one that is just harboring the infection, but has not developed the messenger RNA to induce changes. But that's not widely available. Now, this is all well and good in areas who have laboratory facilities and are fortunate enough to have the finances and the expertise. But in areas, especially your sub-Saharan Africa, your lower socioeconomic, lower income countries, where this is not available, they look at clinical options such as visual inspection with acetic acid and also colposcopy as a screening method. So with those patients, it's usually a one visit where the patients come in, they are placed in lithotomy, cervix is inspected, and if any abnormalities, they have treatment at that point, and they usually have thermal ablation. All right, but I'm not going to go too much into that because that's a treatment option. And colposcopy works the same way. Now, when we talk about the screening in South Africa, initially it was always cytological, and we've been transitioning over to HPV DNA testing. In KZN currently, we use primary HPV DNA testing, but it hasn't been integrated in all parts of South Africa as yet, and it's mostly because of financial constraints. It requires an initial outlay of funds to obtain the machines and the expertise and the diagnostics. And after that, it usually is fine, but it's the initial outlay that there's been a problem in a lot of provinces. So we currently have a mix of cytological screening and HPV DNA screening within South Africa itself. So who's going to tell me about the screening guidelines that we follow in KZN currently? So I did say we do HPV DNA testing. So what are the guidelines? When do we start? How do we divide our group? Anybody? Yes, you can. We're going for broke over there.
But for those who are HIV positive, we need to immediately
Mhm.
those babies.
Okay. I'm not sure if I should let Dr. Morena answer. Okay.
I want to ask this. Your answer, can you just ask where you're working?
Oh, I appreciate it previously,
Yeah.
So you're not involved with actually doing screening?
No, but my case reported was for the HPV, HPV.
Okay. All right. Any other?
I think
John is answering.
So, so previously they were recommending we do, for the low risk, 3, sort of pap smears in their lifetime, so 30, 40, 50. But now with the, developments, they say should be starting screening, as early as 25 years. Less than 25 years is not recommended. So it's 2 arms. It's either they are low risk or high risk.
Now, sorry, how would you define them low risk and high risk?
So the low risk patients are those that have non-high risk patients. Sometimes, and those that are HIV negative. So they will get screening every 5 to 10 years. And if they don't be coming from HPV, they will present a program in the application. But if
Thank you. So one of the reasons I made this interactive is because there's a lot of confusion. All right. So you're not wrong when you talk about your screening protocol. That was the initial cytological screening, right? So when we're using pap smears initially on diagnosis of HIV, they were referred to commence cervical screening. And if you were HIV negative, then you started H30. The newer guidelines with HPV DNA testing we've revised that. So your first thing is you divide your patients into your low risk and high risk according to the HIV status. So if they're HIV positive, they're recommended to start screening at age 25 with HPV DNA primary testing. If that test is negative, then they go on to have a repeat smear in 3 to 5 years, depending whether you're in a well-resourced or a lower resource environment. All right, so if you're in a well-resourced environment, say the recommendation is 3 years. In our public sector setting, we say 5 years. All right, that's one of the advantages of DNA screening is that you have longer intervals between the screening groups. If you're HIV negative, the recommended time is you start at age 30. If it's negative, every 10 years in the public sector. So an HIV negative woman should have 3 pap smears in their lifetime, provided all are negative. Sorry? Yeah, what did I say? Pap smear. Okay, sorry, I'm still old. Pap smears and HIV test is the same thing. So there's 3 tests in their lifetime. And if all are negative, they exit screen by age 60. If they are positive, there's a separate algorithm that they do enter. Okay. And then the third group is your opportunistic screening, is where you say, have, for example, women who present when they're pregnant, and if they fulfill the criteria to have a cervical screening, they done that during their antenatal visits. Okay, even if they fall slightly outside the recommended ages. So what we are going on to next is a demonstration of a pap smear. A lot of times we ask patients, well, why haven't you had a pap smear? You know, I've been to the clinic and they told me I need to have, but I'm scared because I don't know what's involved. So to give us a demonstration and to enable you all to explain to your patients a little bit better, we have Sister Pillay, who is our family planning sister at in Kosi Albert Luthuli Hospital. She also does cervical screening for our staff at the hospital. And it has provided an invaluable service to those who work there, who don't have time to access the service outside of work, because she does it during their lunch breaks whenever they're available. And through her efforts, we have identified multiple patients with premalignant lesions, and they've been treated. And we have had 3 patients who've been diagnosed with cervical cancer, 2 of which were surgically resectable, and they've been through the process and cured. And there was one who was a stage 2 who was cured using radiotherapy. So it shows that the screening program can be effective in premalignant and picking up disease that can be cured. So I'll hand over to Sister Clay to continue. I got something.
Good morning, all. After we talk about Axia, everyone is afraid. Females are very shy about it because it's a very uncomfortable procedure. So as much as possible, we try to allay patient anxiety by explaining the procedure to the patients, showing them the necessary equipment that we're going to use, make sure that the patient empties her bladder before the procedure is done. Okay, so the requirement that you need, your sterile speculum, your brush, a pair of gloves. In Albert Luthuli, we are lucky we have the computerized system, so we just print out a label. But in other institutions, we use a form, a cytology request form, gauze or cotton if there's any exudate that's present, and a good light source. Make sure that you ensure that there's always privacy, patient is covered, your door is closed. And good lighting. So we no longer use any lubricants with the speculum. We just run it under warm water and insert. Okay, so we visualize the cervix quite nicely. Make sure that there's no exudate or bleeding. If there is any, we can wipe it down with a sterile gauze or cotton wool. The brush, you insert the tip into the cervix. Assume you place it at 12 o'clock, and you rotate the brush until a full circle is complete. Come back to the starting point. Remove your brush and insert it into the liquid medium. Make sure that it is not expired and it's also labeled with the patient's correct detail. You insert it into the liquid. You place the brush in between your 2 palms and you rotate it in a rolling movement maneuver for at least 10 seconds, and the brush is removed. Do not put the tip of the brush into the medium, okay? And you dispose this off. Close it nice and tight, and you remove your casters. Ensure that patient is screened again, and inform the patient that she can expect bleeding or spotting post-pap smear, which should resolve after 1 or 2 days. Okay, and then we call back the patient in 6 weeks for result.
Does anyone have any questions?
What was the rationale behind them not using it?
So it was known to interfere with cytological interpretation. So we had stopped using it. Now I think it's just because we haven't used it for a while. just continue not using it. Yeah, well, also works just as well.
So is there any reason why the maintenance speculum is used in
Well, I think it depends on the institution. If you have the disposable one, you can. Most of the clinics will use that. And in hospital situation, if you have this CSSC departments, you send in your medical speculums for which.
It's more cost effective because you sterilize as opposed to using a disposable every time. But you use whatever's available. There's no preference over each of the
Yeah,
other.
yeah, I was in my head just thinking about how often is it like between patient to patient, like autoclaving of this.
All the time.
Yeah.
Every
So it's like you do one at a time.
Patient.
So what happens, there's an autoclave in every phase, and the speculum comes autoclaved and packaged. And it will show on the outside that if you have.
your speculum.
Yeah, the children, I don't think they did from the. And it's not speculum that they can just. From there, they can their bikers, and from the biker it goes back, cleaning, before even on the breakfast, it also clean. And there's a line that shows that it's divided, like all the.
Which is the one
that like.
Prof is talking about. Out here. Autoclave comes, we open it, use it once, and then it goes back. So then look at the plastic one. But we do have on hand if we ever run out of it.
Is the cost. You can imagine they were like in plastic. But I could help more my
Got enough of question? Dr. Moran?
No, I don't know how much a plastic speculum costs. I was shown a plastic speculum the other day that's got a light, automatic on it. It might be quite a helpful thing, because sometimes people don't have the lights. So, that one cost about 37 rand. It's disposable. Got a button and then turns the light. It was 37 rand. I thought maybe could be used that sometime. But this one that doesn't have a light, I'm not quite sure how much it actually costs. Because the metal speculum, I think it costs 200 rand or something like that. People get on $1,000. And then you can use it many, many times. But you have to have enough so that you won't have to reuse them. Before they you have time to clean. So it depends how many you want to do. The other thing I want to ask, without the lubrication, it's more difficult to insert the plastic one country compared to the water. I'm sure it's the one.
Technically, no, they both work just as. You have perfect.
Oh, at the present moment, the form is written side. And the only way you can then get an HPV result is for you to write it by hand. And get the form. And it's an NHLS issue. So if you are going to use the form and send it without handwriting your HPV, you are going to get cytology result and you'll say that HPV was not done. The issue is between the NHLS, they cannot do a test that you have not asked for. And I think we need to get that message out until the forms will come that will have HPV plus cytology that you think for. We will take HPV because our cytology becomes reflex if you are HPV virus. But for now, you have to write it with your hand so that it can be done. They will not perform HPV if you haven't asked them. So I think we need to get that on the clinic.
Dr. Moran first.
Okay, just two questions and one comment. First question is with regard to the name. I'm a bit unsure whether would it be better we continue calling the screening pap smear because everyone knows that name. If we don't call it pap smear and calling it HPV survival screening, something like that, people might not really know what we're talking about. I think most people know the word pap smear, although it's not particularly a pap smear if you're doing HPV. So do you recommend that we just keep calling it pap smear, or should we change that if it's not actually a pap smear? So that's good. Second question, you talked about screening in asymptomatic. That's what screening really means. And you said people will get symptoms once they've got cancer. My question is, to what extent do women with high-grade lesions have symptoms? Because there might be a person who might not meet the criteria for screening, but who has symptoms. And then we say, irrespective of whether they meet the criteria, if they've got symptoms suggesting cervical disease, like persistent offensive discharge or persistent pelvic pain or abnormal, postcoital bleeding and so on, then we should offer screening. I don't know if it's for screening, but you need to investigate that anyway. Does high-grade still cause symptoms? I think that was my second question. The other comment I'll make it a bit later after.
So, to your first question, as you heard, I still call it pap smear. I find the patient's understanding more if I use that than say I'm going to do HPV testing for you. It hasn't really caught on the HPV part of it. I'm more comfortable using something the patient understands what I'm doing, rather than trying to explain and they get confused and I don't know this. So, I don't have a problem using the word pap smear. I think it's better for the patient. Coming to your second part, yes, most of your symptoms are when you have cervical cancer. With high-grade lesions, it is infection, and most patients will have some sort of discharge or discomfort, and sometimes that's what it presents with. It doesn't feel right down there. And I also must commend a lot of our nurses in the primary health care, because patients sometimes go there with UTI and it's like, let's do a pap smear. And that's how the pap smear ends up being done. So you ask the patient and say, well, I went there because I was having this problem. He was burning and they did a pap smear. So a lot of our patients are picked up with symptoms that are really not related to cervical tumor malignant lesions, but they have opportunistic screening.
Yeah.
Okay. Other questions? Yes, that's fine.
So more comment on the technicalities of the vaccine. So when I'm training, I find the two big gaps in the knowledge is what Prof mentioned, that you're supposed to cross other and write HPV. And that is why when you look at the statistic, there's about 13,000 HPV tested and 10,000 cytology tests done as the first test, is because people are forgetting to cross other and write HPV. And the second thing that NHLS told us about was when you're putting the barcode, you put the barcode horizontally at the bottom of the bottle rather than vertically where the space that one would default to put it. And I find most of the registrars that we train are putting it up and down, and I've had to tell them to put it across, which is for anyone to know. Well, because the machine reads the barcode horizontally.
Thank you for that, Dr. Pat. Mr. Pillay, you had
I was just going to say, so I'm reviewing the HPV, I should send the specimen to biology instead of cytology.
So initially at Alba, we also had the same problem where there wasn't an HPV test on the system. So we should pick the cytology and write there for HPV testing. But now they've developed an order for HPV testing on our system. So if for us, it goes directly to virology. It's coming, the paperwork.
Yeah, so just those practical things. I think the comment that was made by Prof about writing the tests, that's what we have to do. We have written and discussed with NHLS that when they're designing the next version of the form, because I think there's a sort of printing tender or whatever, that it should have a separate HPV tick box and survival screening. So hopefully that will get rid of that issue. Now, the other comment I wanted to make, it comes from like the first comment that the suggestion that was made that HIV positive women, as soon as they're diagnosed with HIV, they should have a vaccine done. So the new protocol where we're using HPV, that is not the right protocol, because we have a lot of young HIV positive women, and as you presented, probably most of them have HPV, but it will go away and it won't cause a problem. So if we are just sending all the 20-year-olds, 22-year-olds, or 17-year-olds who are vaccinated with HIV positive, we're going to get huge numbers of positives, and they will often have maybe low-grade cell as a finding. And if they are then referred, then we're going to be doing inappropriate treatment for people who don't really need treatment. So I think what I've realized is that there was inadequate communication about that aspect, because I've even heard that in some places, in some districts, there've actually been various people will be saying, you must do the screening for every HIV positive woman. And in other words, going against the protocol, which we put in place because we realized that it was a problem. To do that. So I think we just need to re-emphasize that message. Maybe put out a circular, just re-emphasizing that message. It's not to say someone can't have a pap smear if they've got symptoms at any age, but we mustn't try to increase our pap smear coverage by doing pap smears in people where it won't be useful. And all it will do is lead to inappropriate referrals and clogging up the treatment site with too many patients.
Thank you, Dr. Moran. So thank you for that session. I found it quite fruitful.
Yeah, 1 minute. So if you have an HIV positive, these days they say we mustn't use that word. It's women living with HIV. You have women living with HIV where they have symptoms or you see something on their cervix. They are less than 25 and you really want to screen. The best way is to do cytology. As Dr. Moran said, it's gonna be high anyway. The rate of HPV prevalence is higher in there. So if you want to screen a woman living with HIV lower than 25, the best is to go straight for cytology rather than look for HPV, because you are worried about, or maybe the cervix looks abnormal or whatever. That's better just go straight to cytology, because that's the one that will tell you have the cells started degenerating or migrating in a normal range.
Okay, thank you, Prof. So again, thank you everybody for that session. I hope it was fruitful for everybody. So our next speaker. Okay, Dr. Shangase. Yes, I can see you're trying to avoid the inevitable over here. Yeah.
So I have a question, more clarity point, because I have a question about almost what in pregnancy. When you have a high grade or low grade one pregnancy, what happens?
So we would do a normal colposcopy for the patient. Remember, colposcopy does not always mean biopsy. Colposcopy means visualizing the cervix under magnification after application of acetic acid or Lugol's iodine, but you don't use Lugol's iodine in pregnancy, acetic acid. If there are any overtly suspicious areas that you're concerned for invasion, you do a biopsy, punch biopsy, right? And you treat them depending on that result. A routine LETS is not indicated unless you are really, really concerned that there may be invasive cancer, but a cone biopsy is more is preferable over a LETS because there's less chances of interfering with the actual pregnancy using a cone biopsy. Does it answer your question, Dr. Moran? So Our next speaker is Dr. Sangase. I've been acquainted with Pam for many years. Back there's a registrar program where she was very junior and I was very senior. She came and troubled me at Lutuli when I joined the unit there. She's like, I need a job. I don't want you. But I really like oncology. Through the years, she's been a pillar of support to me when she was my original minion, getting through the steps of establishing the gynecology unit at Lutuli. And then she left to pursue her own passions. And then one of her main passions is prevention of cervical cancer in our population. She's worked for a couple of years up in the Zululand district, first at Lower Mfolozi Hospital, and then with the Health Systems Trust and promotion of cervical cancer screening. And we noticed a huge difference when she was there in the patients that we were getting. It's no small feat that I'm extremely proud of her. She's currently a consultant at King Edward Hospital, or VMH. We are hoping that she's going to be joining us in the unit soon to start specialized for enormous potential when it comes to that. So today she's going to be talking to us about HPV vaccination. I'm going to hand over to Dr. Shankar. Hi.
Morning, everyone. I'm Dr. Changase, as she's already said, when she's introducing me like that, it sounds like I'm going to say something big. I promise you it's just going to be basic and to try and make things as simple as possible. So, okay, technology is failing me. Okay. Okay, so when all right, firstly, I am not, I don't have any conflict of interest. My only interest is saving lives and fighting this monster called CA cervix. I'm going to quickly introduce the talk, background of cervical cancer and HPV. Most of it has been touched by Dr. Mold and Dr. Atisha, so I'm not going to go into details of that. We'll just be browsing through that so that we actually focus on the more important things. So we know that the global incidence of HPV-related cancers is high, and it's not just cervical cancer, but there's a whole lot of other diseases that are affected or basically we get from HPV. We know that it's mostly sexually transmitted, and I think that's very important when it comes to the vaccine. As already been said, I think Dr. Mold mentioned this, that when we have HPV infection, most of us naturally clear it in the body. And it's only those that have persistence of this that have a problem, and then it eventually leads to the pre-malignant lesions. So if you look at South Africa, you can see there in the teal, the actual promotion ribbon for cervical cancer is teal, but that's not what we want to look like. Because it just shows that our incidence is quite high. If you look at Africa and then specifically South Africa, our incidence is still quite high. So that's not good. So that's what we're actually trying to fight against. So the cervical cancer control is founded on a primary healthcare principles, which says prevention is better than cure. So when we look at the prevention strategies, we've got about 3. Primary talks about us actually trying to reduce the incidence of oncogenic HPV infections. This is us trying to make sure that we actually prevent the disease from actually being acquired by the patient. Secondary is the treatment, which Dr. Atisha was actually talking about, and then we've got tertiary prevention. So the immunization actually plays quite a critical role in combating the burden of vaccine preventable diseases. And if you look at the EPI program, you know that there's a whole lot of vaccines that are given to children, which have helped to actually reduce a lot of the burden of the disease. And when it comes to cervical cancer, we are hoping that we can actually achieve the similar goal. So the high-level vaccine trials have shown that it is highly effective, preventing more than 90% of infections and pre-cancer lesions that are HPV related. We know that they are safe, but I'm going to go into that. But we know that over 2 million, in fact, I think when there's more trials that have been done and there's a lot of patients that have been given HPV vaccine. So we know that it is safe and it is actually effective. Right. So the vaccination has been shown to be very effective, right? When it is given ideally before acquiring the actual HPV. That means if you give a child or the younger adolescents before they actually start having sex, then the chances of them actually clearing it it's better than an adult. I'm going to go into that at a later stage. It is not necessary to screen a patient before you give them vaccination, especially with the younger ones, because we know that 12-year-olds who cannot be obviously doing a pap smear on them. So you can just give the vaccination. There is also strong evidence that if you cover or you vaccinate enough people, you will be actually creating what we call herd immunity, which means you can actually give a protective effect to the community as well. So we said that there's different prevention strategies, and vaccination falls under the primary prevention, which also has male circumcision, there's education and all of that. So, but we do know that the most effective of them all, and one that we are able to measure properly, is vaccination. So WHO formulated a strategy which we call 90-70-90 strategy. And this aims to eliminate cervical cancer or basically reduce it to at least 4 per 100,000 women by the 2030, right? Unfortunately, I think Dr. Moran knows this, our statistics at this point in time are a bit shady, so it's not quite clear where we are yet. We do have some figures, but we know those are not accurate. So similarly to those who are in the HIV space, we've got the 90-90-90, which is now 95-95-95, which are goals to eliminate HIV. You've got a similar strategy for cervical cancer, right? But when it comes to vaccination, this falls under the first 90, and the aim is to vaccinate at least 90% of girls must be fully vaccinated with the HPV vaccine, an effective one, by the age of 15 years. Then we know if we do that, we are eventually leaning or going towards elimination of cervical cancer. I think we already spoke about this. So if we prevent the actual integration of the actual virus, then you are preventing the progression that we actually spoke about. I think there's Dr. Mould went into details on this one, so I'm not gonna go much into details about it. But it's important to know, as he already mentioned, that there's a lot of other viruses that are basically related to each other, and there is a genome differs about 10%. That's where you actually define a new one, and that's where actually cross protection happens when it comes to the HPV vaccines. So just a quick immunology lecture. Remember when we are young, right? With all the viruses, you actually get a virus or bacteria or whatever pathogen that you get, right? It will be taken into by the cells, and then that's when the whole process happens and you start to get the natural immunity, right? And that's when the B cells, which Dr. Mould was talking to, actually happen, right? So the principles then of immunity is that when you actually introduce a vaccine, you are introducing something that is similar to the pathogen, and then the immune response is going to happen, which will create memory cells. However, because this pathogen is remember, the first response is the most important, and it is the one that will actually decide how strong the immunity is. So the theory is that when you actually give the patient this prior to a pathogen being introduced to them at a younger age, then they're going to produce a higher immunity, all right, and a stronger immunity. And when the time comes that they actually are having sex and they acquire HPV, they are ready to clear it because the memory cells will then remember and recognize this pathogen, and then the antibodies are then produced, and we then prevent that entry, not the entry, but we prevent the persistence of the HPV in the disease. So the vaccines are prepared from a highly purified vaccine-like particles, basically of the major caspid L1 protein, which Dr. Moll spoke about. The vaccines that are currently being used are non-infectious recombinant, which means there is no live DNA in those viruses, so you cannot infect the cells. It's just mimicking the pathogen in order to actually produce that immune response. There are adjuncts that are used in different vaccines, and then those actually enhance the immunity so that the immunity that is actually produced from a vaccine is higher than the natural response. Okay, and if you look at this, and I think Dr. Mold actually had a similar slide with abrasions that happen, you actually, when the HPV enters the basal cell through the microabrasions, then the wound exudate contains high titers of L1 IgG antibodies that are specific to the HPV, and then this will actually help to clear the HPV faster. So that is basically how the different vaccines work, the different HPV vaccines work. So the HPV vaccine was first licensed in 2006, approved by FDA, but in South Africa, we only had it from 2007. So we actually had it for some time, just not in the public sector. So World Health Organization recommended that we must give the girls that are between the age of 9 to 14 around 2009, and then the Department of Health actually responded to that. And I've already mentioned that the reason why this age group is chosen is because there is a higher immune response, and because most of the patients or girls at that time have not started having sex. So we want to catch them prior to the sexual debut. So we've got a bivalent vaccine. This was licensed in 2007. This one targets HPV 16 and 18 subtypes, which is responsible for about 70% of cervical cancer. And an example of this is Severix, and that is what the one we are actually using in the school health program for our girls in South Africa. It is indicated for use in males as well, but obviously at this point in time, our Department of Health does not cater for them because of cost issues. Initially, it was recommended as 2 doses at 0 months and 6 months, basically every 2 twice a year. But I'll speak about that a little bit later. Then we have moved from that dose. However, it is important to note that HIV positive population, that studies that have been done have shown that they actually do mount a response as well. So we do not exclude HIV positive children from actually getting the vaccine. The only difference is that with them, you don't reduce the doses. You actually make sure that they get all the doses, because we're not really quite sure of how long the vaccine efficacy actually stays with them because of the studies that have been done. We've got the quadrivalent vaccine, and this one was also licensed in Europe in 2006. And this one, additional to 16 and 18, covers then your 6 and 11, which we know is more for the warty lesions. So it's indicated for use as well above the age of 9 for both males and females, and the dosing schedule is similar to the one that we use for Severix. So studies have been done. I'm not going to go into that, but we do know that it is effective. On the studies that have been done, they have shown both quadrivalent and bivalent vaccines to be useful. And they obviously use different adjuncts, but all of them has actually been proven to be effective. And in 2014, WHO issued a position to say that HPV vaccines 2-dose schedule for immunocompetent females ages 14 and under are equivalent to 2 doses versus 3 doses scheduled in younger adolescents. So at this point in time, there is no need for boosters. Both vaccines are actually given on a deltoid, and unfortunately, which is quite an issue in our areas, especially in the rural areas, you do need a cold chain because they actually need to be stored at a certain temperature. So, but they are safe when everything has been, or the right protocols have been followed. And I just want to clarify that there's different vaccines, right? The ones that we are talking about are prophylactic vaccines. There are therapeutic vaccines, which I'm not going to go into details about. The nanovalent, this is the one that is on top of coverage with the quadrivalent. It then covers 31, 35, 45, and 52 and 58. And we do know that most of the cancers, or more than 90% of the cancers, are caused by these viruses. And then additionally, I think one of the most important points to mention here is that the increment of cancer protection on this vaccine is seen, which is around 5% associated with global 52 and 58. So that's the additional cover that you get when you're using the quadrivalent, the nanovalent versus the quadrivalent. But we do know that both of all three are still actually effective. The example of this one, I think, is Gardasil 9. The studies so when it comes to issues that we have, is that the cost issue is here. So each country needs to actually evaluate the cost effectiveness. I'm saying this because most people have asked why we in South Africa are using Severix instead of using the one that we know is more effective. However, we need to look at the cost benefit. I think if you look at the prices with the Severix, the government is able to acquire it at less than 350 for each child. But when we come to the quadrivalent, we are now going to at least 1.2 per dose, and the nanovalent is about 2.5 per dose. So you can see the cost is quite differing there. When it comes to studies that have been done, there's been quite a lot of them, and we do know that I think the latest, or that I've come across, I think Dr. Atisha and Prof can actually assist here. The one that we've come across is the one that actually has the longest was 12 years, a vaccine, to show that, or has been studied to say even up to 12 years, the vaccine is still effective, and there's still quite a high number of immune response to the HPV, even at 12 years after the actual injection. So we know that it's effective. I've already mentioned this, that a lot of girls have been vaccinated. More than 60 million people have been vaccinated in different countries, and there's very minimal reactions that have happened because of this vaccine. Most of the side effects are like mild, maybe the reaction at the injection site, swelling, itching, rash, readiness, and all of that. But most of them are self-limiting, and most of the time they make sure, and when the vaccine is being rolled out, that there has to be obviously a resuscitation trolley, and not a trolley, but the drugs that are emergency drugs to actually try and combat this. And patients will actually be observed for a few minutes before they actually can go. So the girl will be injected, and then maybe for about 15 minutes, you actually follow them up and monitor them. And then only after 15 minutes, you can actually release them. But we do know that there's very minimal side effects, and there has not been any deaths that have been reported through this vaccine. When just comparing all three, it's just a summary to show that there's different adjuvants obviously with each, so you need to be cautious of that. The age is similar that we are using. The injection site is the same, and the similar or reaction profile when it comes to side effects as well. The therapeutic dose and therapeutic vaccines that I spoke about, we don't have them yet available. Most of them are in clinical trials. So those are the ones that speak to if a patient already has CIN3, for example, can I give in order to try and hear that? And we don't have them yet in our setting. However, we know that the vaccines that we have, okay, there is some controversy, and the trials that have been done are not showing us clear results, but I think there was an Clarity trial and a few other trials have shown that there might be a possible reduction of CIN1 or CIN2 if the patient actually has been given a vaccine. But obviously, we don't recommend that we now take a patient that has CIN2 and say inject them with the vaccine in order to clear. So it's not a therapeutic, it's not indicated for therapy yet. So in South Africa, we started this program in 2014. It was a big buzz in the social media. And with this campaign started, and it is part of the integrated school health policy and program. We know that there are nurses that go to the schools and they do dental therapy and a whole lot of other assessments like hearing. So it is part of this program. So then they go, these different campaigns are run throughout the year. So most of our girls are actually given vaccination through this one. So the girls between the age of 9 and older are the ones that are given. Initially, it was grade 4. Then it was established that some of the girls have not reached the age of 9 by grade 4, so we now shifted to grade 5. At the time when it was started, we were giving 2 doses, but however, at a later stage, WHO released a statement after a whole lot of data that suggested that single dose is actually equally protective for girls. So we now have moved to a single dose for several in South Africa. This is the Department of Health policy. And that was after a lot of consultation with the advisory committee to say that can we now move to that, because there's a few issues with that. You can reach more girls with 1 dose instead of the 2 doses. It's actually cheaper as well for the Department of Health. So as I mentioned before, we don't have studies that are sufficient to show that a single dose will be sufficient for an HIV positive population. So we still continue the normal doses for that. The exclusion for this is that the quintile one, we only are injecting in public, or the vaccine is offered freely, right? For in public schools, quintile 1 to 5, and all boys are excluded. So the boys are not given this vaccine through the school health program. And anyone younger than 9 will not be given. And at this point, there's no catch-up program. I know that they are working on it to make sure that those that have missed and they are above the grade 5, then they can be given at a later stage. And obviously, the ones that are attending private schools, you actually have to do it at your own cost. Topics or things that are topical right now is immunizing males. And if we immunize the males, it would not work better, because obviously the transmission is through a male. We do know that this will actually quite help, but at this point in time, I think the aim is to vaccinate the girls, and at a later stage, they will be added because of the herd immunity that we speak about. When it comes to vaccine coverage, it is quite improving. And if you look at the diagram there, in 2011, we actually didn't have any in Africa, but there is quite some significant improvement, and a significant proportion of the African population is now being covered, and we know that that's where we actually need it the most. The challenges that we have, it's the high cost of the vaccine. I already mentioned to you the numbers that we talk about. And if you look at the numbers that we're talking about, remember that the quadrivalent and the nanovalent, we are saying at this point in time that we need 2 doses, but we do know that the one is also still effective. So if you are getting a vaccine, you actually need to pay at least 1.2, second dose another 1.2. So it's a total amount of about 2.5. And if you are getting the nanovalent, it's about 5,000 in total. Consent. So we know these are young girls going to school, so you need a consent in order to be able to vaccinate them. And we do know that there are issues with this, but this is the policy by basic education that the girls need a consent in order for them to actually be given the vaccine. So you cannot vaccinate a girl who's not been consented for. And this vaccine is not compulsory, so the mother actually has to consent. There's issues with documentation, but they are improving because it's not on the initial EPI program where, you know, with the card that all our children have, it's not yet there. It's just pasted most of the time, but they are developing new ones which will be inclusive. Cold chain, I think I already spoke about that, and we know our temperatures in South Africa and African populations. We also have this high vaccine hesitancy, and we know that there's people that are anti-vaxxers, and there's a lot of messages that are being spread across the social media about why this vaccine is actually created and to depopularize the community and all of that. But there are no actual studies that actually prove that at this point in time. We do know that also during COVID, we also had a decline of young girls that were vaccinated because of the lockdown. And on top of that, it actually made worse the vaccine hesitancy issue because of the COVID vaccine. But we do know that so far we have not had issues with the COVID vaccine. When it comes to screening, we still obviously have to create guidelines that are tailor-made for patients that have had the vaccine, but we do know that it does not completely protect you. So even if a patient or a child or a young girl or even an older adult has had this vaccine, you are still required to actually screen them. So what we need to do now is obviously expand our coverage by implementing a catch-up program for girls that have missed, girls that are in private schools as well, because just because someone is in private school does not necessarily mean they can afford the doses in private, although they've been offered. And we need to improve on our social mobilization and awareness strategies. And together working with the screening and everything, then that is the only way to actually reduce cervical cancer. So in conclusion, prophylactic vaccines are immunogenic, they're safe. We know that they're effective against the HPV infections, and also some other specific type of genital lesion, including CIN, when administered prior to HPV infection. The introduction of this vaccine is a significant milestone. I think for us, we need to commend our government for actually introducing it. And obviously, because of the age that we are giving the vaccine in, we're still going to take about another decade or two in order to start seeing the decrease in the cervical cancer due to the vaccine. So in addition, obviously, we need to continue to strengthen other things. So just because someone has had a vaccine, it doesn't mean they must now really have unprotected sex. We must still emphasize on those things, and male circumcision and cessation of tobacco use and all of that. So we know that there is a significant population that needs to be vaccinated in order for us to cover. And it's also important to know that most of the studies are now saying, or the age, when it comes to age restriction, they are now saying that, I think initially it was age 12, or it was 26, it was moved to 45. So at this point in time, we're saying there's not really a proper age cutoff. So anyone can actually have a vaccine, HPV vaccine. So on that note, if you have not had vaccine, please go outside. There are nurses that have the vaccines outside. They'll explain to you further. And if you're interested in having an HPV vaccine, you can actually have it today on site and see for yourself. Thank you.
Thank you, Dr. Shanase. Are there any questions, comments?
Hi, not that you can answer the whole, you said what I said. Not to be patient with the comment. I was wondering, why I'm raising this student response, which is especially when the private schools. Was those that kind of this the purpose of just vaccinating the dog and then we do have the name still, we do have to use the carriers and then we're going to them more people are not doing. Some other question is also, it's almost like, the challenge is anything as a teacher team, I'm not doing for them. What are doing during the vaccinations and the meals that are just like this on the vaccine? What are the chances that, or that, you are going to be able to cover up or vaccinate the meals in terms of the basically?
Very good comment or question. It's a challenge that I think a debate that is ongoing, and I think the Department of Health is looking into extending the program to males. But at this point in time, we know the resource constraints that we have, and I think it's purely based on that we have not started at this point in time. But that is one of the things that we actually need to.
Okay.
I think Prof has.
If I can just, add to that. So if you look at the WHO recommendations for your screening groups, your primary group is your females between ages 9 and 12. That is the group that is targeted everywhere, right? The additional groups, the ones that you're older than 12, over 26, over 45, and the boys are a separate group altogether. So the WHO recommends your initial target be your pubescent girls. And once that group is adequately covered, then you can expand to include other groups, including the boys. Because there's been shows been no benefit to including everybody if your primary group is not effectively vaccinated. That said, when we're talking about herd immunity, there is a suggestion that if you cannot achieve 50% vaccination minimum in your primary group, that you include the boys just to make up your numbers. But your primary group should always be your girls. And once those are covered, then you expand to include other groups.
Currently in our program, which obviously only covers a percentage, we know that the school health program covers at least 90 something, over 90% of girls that are in the public health schools.
Sorry, just to add on to that, there's been a change in the vaccination program as of this year. Right. So previously it was only in the public sector schools, private sector had to go and buy the vaccine. It has changed to that the program in the public school sector, they're given 1 dose of Severix as opposed to 2 doses. If you have a learner who's HIV positive, they're given a letter to go to the ARV clinic and they get the 2nd dose of Severix as part of the ARV package. The additional doses that were previously utilized in the public sector has now been mobilized to include private sector schools, although that is being introduced in a stepwise fashion. Because there was always this sort of argument that why only public schools, and nobody really looks at the cost. People look at, do you think that our children are more promiscuous, that they need this, or not understanding the real reason behind it. So it always be more inclusive in an attempt to make it more palatable. It's palatable. Yes, to the public. It's been expanded to include private schools as well in the program. Sorry, Prof. I kept cutting you off.
Why and the thinking of why I did think there is something different in terms of what you're trying to achieve. What the ultimate goal of the vaccination goal at the 90. Not to say that boys are number one potential carriers, but remember that people have cancer as well. It's as you say, the patient they themselves are. But when you look at cervical cancer, it's one disease that they have a target for 2030, which they believe can be achieved of eliminating their cervical cancer. Simply because of the rate of progression from, there's a pre-malignant can vaccinate and blah, blah, all of those. as opposed to, even the urologist when you ask them, yes, HPV 16 and 18 is associated with penile cancer and a whole lot of other cancers, colorectal, whatever else, even breast, by the way. But they don't have a pre-malignant lesion that they can chase after like linear. So it's really about what you are targeting and what your outbreak goal is. And when you look at even developed countries that are looking at this target, target, Australia being one of these that is posted, they have a vaccination program. It's mainly focusing on development. So we are developing LMIC, but we'll get there. I think putting the resources really helpful.
Yeah, it's thinking of the things that in line with those of the Chinese machines spoken on device. That you were actually like making sure that meeting with the party, so I'm ready to lay off them at the level of those.
It depends what the question is whether we are in line to meet the 2050 target. I don't think we will. What the goal is to reduce death from cancer. Now, I think we will get them. We as a country may not realize we have to start here. I don't think we will not see a death from cervical cancer in we will still see. When you look at those three silos as to whether the 90% of women will screen, 93 decimations that will be screened. I think it will be possible. I'm very optimistic that the noise is getting louder, patients are presenting, and we're one of those countries that really have put our money where our mouth are. It's just to really get but the last one of the is that the have done with HST said we are 30% at between versus and by the way, even that is one of the leading provinces when it comes to updates. But we can look at there's activations everywhere, there's whatever. So I think we may not really reach that, but we'll be closer.
I think Prof's been a bit modest about the achievements that we have gotten in the past 10 years. And indeed, the other provinces have often asked us, how have we done it? Because our screening uptake has improved. It may not be 90% as yet, but we're getting there. Our vaccination uptake, it suffered in all provinces with COVID, but we're steadily increasing that as well. But where we excelled most, and unfortunately Dr. Moran has left, who was very instrumental in decentralizing our treatment of pre-malignant lesions, getting more colposcopy machines out there, training more people to treat pre-malignant lesions in an effort to decrease the number of malignant cases that we have. Also, the oncology department has really stepped up when it comes to treatment of actual cervical cancer. Previously, when we first started at Luthuli, our waiting times for radiotherapy was over a year. Addington machines were non-functional. In the time we've gotten Addington machines functional again. We've established radiotherapy units up in Northern Natal with its own oncology team, which has significantly decreased the burden at Albert Luthuli and Addington. The only sore point at the moment is Gray's Hospital, because we're still trying to improve their capacity and decrease their waiting times. That's the only challenge we have in decreasing treatment times for cervical cancer. So, like Prof said, we will not actually achieve those numbers, but we will be close to it.
Sorry, for those that are.
This last 90%, just is correct. We are one of the few provinces that have got other provinces who only get a proper voting at regional government. For us, it's close to, I think, before 2018, when we had our last campaign. For example, we set the record of screening in 2018 of record 2,000 screenings in 1 day. Since then, we wanted to be by the end of this month. There is a campaign I think coming. So we are doing fairly well.
These machines were rolled out, I think, close to 8 years, the addition of purpose being everywhere, not purpose, lenses being everywhere. We have also rolled out a few devices on thermal ablation, which can be done by a nurse. The other provinces are following. So this last 90% we do very well in pre-malignant disease and as you said, in now cancer. The 90% we got the first one, yeah, but then the 70% we will try. This yesterday I heard that the province has sent out a circular to all the districts to screen 1,000 women by the end of the month. If we can do that as Prof and the NTP district was giving 2,000, duplicated in or better. So I'm just saying, for all of you who are interested, please dial the 23rd of this month will be at 6 summit, all hands on deck. If you can do this here, we need your help. So there's a campaign coming up, bringing that similar to that one we've done again. To reach out to what is called the team area with Phoenix, Inanda, Kizuma, Kwamashi, yeah. It's organizes many.
Okay, thank you. Yes.
Thank you so much. I think this is becoming a very interesting discussion. I have a question around HPV herd immunity and the efforts towards trying to reach that. Are there any efforts that you guys are doing to kind of like catch up with HPV vaccination, especially to those people and missed out the vaccination because those who have already older than 9 to 14 years and 2014 when the vaccination was initiated, but who are still pretty much very young, qualified to be vaccinated in the public spaces. So I think my question is, if maybe my 24-year-old sister was to get vaccinated for HPV, will she be able to get it?
So that's unfortunately not yet, but it is on the pipeline. It's on the plans. As I think Dr. Atisha said, that we are looking at the different targets. So they obviously are extending to the high school girl, to the private school first, and then there are plans. How do I say it? It's a stepwise approach to add those people, but it is in the plans. But it yes. In private, yes.
And the medical aids are, and it doesn't affect your baby, whatever.
Is paid from risk.
Yeah, so it doesn't affect the daily pockets, so you can still get it. The guidelines, because there are guidelines there for vaccination, people are covered in the most. That's how we now. Right? It's up to the age of 45. That's why the vaccination are outside.
Yeah. I just wanted to mention a point about the 70 to where we are right now. For those that are interested in numbers, there's an annual district health barometer that looks at cervical cancer screening, and it looks at all 52 districts and actually shows in fact where South Africa is. We obviously not nowhere close to 70%, but we are improving. But it actually gives you by district, by province, and as I think Prof mentioned, we are leading as KZN, but it actually just shows you how lagging behind other districts or other provinces when it comes to this. But it will give you the actual numbers of where we are. They are collected by the districts on a monthly basis.
Maybe also you guys keep the records of people who are vaccinated, because I think the other families that we have, especially as Christian. So I've been on the research that in find out the vaccine for HPV, and I think the greatest challenge was that when we ask people
whether they've been vaccinated or not. We don't know until the spring comes up. People don't know. So I think if the public of health keep the rest of the things that I mean.
So they do keep the records. Unfortunately, most of them are paper-based, right? For them. So it's a very highly guarded recipe like KFC, but they do have the statistics of exactly how many people have been vaccinated and the names. Unfortunately, as I said, they just attach a card on the API program card. So sometimes a thing tells, then someone might not necessarily know whether they've been vaccinated or not. But they are looking into editing the actual card so that it's part of the normal vaccines, and the kid will actually take that to school and they'll sign on that card. Yeah. But it's not really available. You have to request from the department. They are able to give you. Yeah.
Thank you, Dr. Shankar. So I have more questions. So what I want to know from the audience here is, this morning before you were coming to medical school for this wonderful program, you got into your car, switched on the ignition. What was the next thing you did? Aside from doing your makeup. Coffee, okay. You took a sip of coffee. Anything else? Before you drove off, what did you make sure you did? Put your seatbelts on. Why? Yes, the car switch is off. Good point. Okay, aside from that. So safety prevention, right? So the idea behind the seatbelt is known to decrease your chances of dying if you meet an accident. So what are your chances of dying if you meet an accident? If you get into a serious accident? 1 in 10, 1 in 20, 1 in 100. It's 1 in 656. That is the chance of dying if you get into a serious accident. That is what your seatbelt is preventing. So we all put our seatbelts on this morning. To the ladies, how many of you have had a pap smear according to guidelines? Your chances of dying from cervical cancer is 1 in 45. We all put our seatbelts on this morning, but we're not taking steps to prevent cervical cancer mortality. So it starts with us. Okay, before we go out and talk to the audience out there, it starts with us. So if you look at the program, our next speaker was supposed to be a survivor. And unfortunately, she declined to be here today on the basis of that she was recently diagnosed with the recurrent. So she was diagnosed about a year back, received her treatment, and she was going well, and now on scans, she was found to have a recurrent disease. I spent about 45 minutes with her on Wednesday. She's extremely upset and did some counseling, etc. But yeah, so she sends her apologies. But when I ask her, and she's agreed to let me share this with you guys, what is her greatest regret? And her greatest regret is that she never did cervical screening. And I am talking about a professional nurse. She never did cervical screening. She only went to have testing done when she had symptoms. And by then she was found to have a stage 3B cervical, which was cured initially, but she has recurrence now. That is the greatest regret. And the reason she didn't do it is in her mind, it's not going to happen. I'm a professional, I am stable relationship is not going to happen to me. That's not something we can easily say. We can only safeguard ourselves. And I think the fallacy of the human being saying it will not happen to me. Because aside from her and her story is, when the vaccines came out, I was approached by many colleagues at Albert telling us, I have a daughter, the school has sent this. Should I get her vaccinated? I said, yes. No, but this is not going to happen to her. Like, how do you know that? You cannot predict the future. The best way to avoid it is to prevent it from happening. Get vaccinated. Get your screening done at regular intervals. That is the only safeguard we have. 1 in 42 women in South Africa will be diagnosed with cervical cancer, and 50% of them will die. That was the latest stats that were released by the HPV Forum. So we have a disease that is entirely preventable. We need to prevent it. Okay, so moving on to our next speaker. It is our head of clinical laboratories, microbiology. Sorry. I'll get your name. Sorry? Prof. Abai, yes. She is the head of the clinical laboratory services here at UKZN. She has a special interest in STIs, and she's going to talk to us about the interaction with HPV and STIs. Thank you. Thank you.
Good morning, everyone, and thank you to Prof. Debatlani for giving me the opportunity to speak to you this morning about basically my field of research, which is the other sexually transmitted infections, because HPV is also sexually transmitted, right? There's going to be a lot of science, but I'm hoping that we kind of get the gist of what's gonna be said. So if we look at the statistics that has been released by the WHO, worldwide, there are more than 1 million people who acquire a sexually transmitted infection every day. There are 374 million global cases each year of the 4 curable STIs. So you must have heard about chlamydia, gonorrhea, trichomoniasis, as well as syphilis. So they are categorized as the 4 curable STIs. But when we look at the viral STIs, more than 530 million people are living with herpes simplex virus type 2, and more than 290 million women have a HPV infection. So STIs have serious health consequences. Most of you working in the public health sector would know this as well. And they can be caused by more than 30 different bacteria, viruses, and parasites, which are spread predominantly, like the name suggests, by sexual contact, including vaginal sex, anal sex, as well as oral sex. If thinking you're doing oral sex and you can't get an STI, that is a misconception, right? Because you can get a pharyngeal STI. So if not detected and appropriately treated, several non-viral STIs can result in pelvic inflammatory disease, ectopic pregnancy, and infertility. And these guys are mostly the chlamydia and gonorrhea that cause this type of havoc, right? And we know that STIs affect mostly young women. The reason is because the young women, they have immature cervixes, so they are more likely to acquire the STI by breach of the vaginal barrier, right? So STIs, surprisingly, rank among the top 5 categories for which adults seek health care worldwide. So of the pathogens that are linked to the highest STI incidence, syphilis, gonorrhea, and chlamydia and trichomoniasis, as I mentioned, are curable, whereas the 4 viral STIs, which are the hepatitis B, HSV, which is herpes simplex virus, HIV, as well as HPV, are characterized by their incurable nature. However, although they may be incurable, they can be appropriately managed. So effective management and control of these STIs can be achieved through proper treatment interventions, as you're all mentioning vaccination, thereby mitigating their impact on individuals affected by these infections. So STIs have also been considered major causes of inflammatory cytokine upregulation and recruitment of immune cells to the genital mucosa. I'm sure you had a talk this morning about immunology and HPV pathogenesis. So it kind of ties in with the cytokine storm that is taking place, or the regulation of the cytokine. So let's look more locally now. So South African studies have showed that chlamydia trachomatis, Neisseria gonorrhea, Mycoplasma genitalium, these infections coupled with elevated cervicovaginal concentrations of interleukin-1 beta, interleukin-6 for the immunologist, interleukin-8 and soluble CD40 are associated with an increased risk of HIV acquisition. But why are we talking about HIV, right? Let's just look at a nice scaffolding effect now. So studies have shown that women living with HIV are 6 times more likely to develop cervical cancer. So if STIs are causing an increase in HIV, there's our bottom layer. Then we've got HIV sitting on the top, and HIV is basically increasing your risk for HPV infections and cervical cancer. So it's a scaffolding effect, and it's showing that STIs, which you probably didn't think about, were responsible for indirectly causing cervical cancer, are actually one of the role players. Now, we all know that HPV is the main etiological agent for the development of cervical cancer. HPV causes 570,000 cases of cervical cancer and 311,000 cervical cancer deaths each year. Although there are geographical disparities in HIV prevalence, Sub-Saharan Africa has the highest global prevalence of HPV. It ranges from 8.5% to as high as 74.6% among women with normal cervical cytology, which means that the infection could be there, but you could not be manifesting clinically. So the risk of HPV infection is skewed toward young women who engage in sexual intercourse early in their reproductive years, mostly women that have a sexual debut younger than the age of 16 years. They are more likely to develop these infections. So let's look at South Africa again. Young women that are younger than 25 years of age are disproportionately affected by HPV and high-risk HPV, with prevalence ranging from up to 70% for just HPV overall, any HPV, and 50% for high-risk HPV. So the prevalence of multiple HPV infections and incidence of cervical cancer in young women varies depending on different ethnic groups and geographical location. But when I'm going to discuss the studies, we're going to bring it home. We're going to talk about Africa and South Africa, right? So cervical cancer is preventable through HPV vaccination, which you've heard by our previous speaker, if it is administered before exposure. So they mentioned the age group, why you want to get them before they become sexually active, right? So HPV vaccine coverage has been low, while incidence rates remain high in resource-limited settings. So data from South Africa has shown that 3.2% of women in the general population, they harbor the high-risk HPVs, which are responsible for cervical cancer, which is your HPV 16 and 18. And 64.2% of them will have invasive cervical cancers that have been attributed to these genotypes. So if you notice with the partial genotyping that could be implemented as one of the layers of the screening algorithm, they're looking at mostly HPV 16, 18, or 45. Rationale, they are more responsible for the invasive cervical cancer. So the eye burden of HPV infection is influenced by several factors, including co-infection with other STIs. And we're going to look at some studies where we've seen this data, right? So HIV, another viral STI, is a significant independent factor of HPV. And infection with either HPV or HIV is thought to enhance the spread of the other infection. So it's a bidirectional relationship. It's not one-sided. You go in either direction, it increases your risk of either infection. So the effect of HPV and HIV co-infection has been established, and women co-infected with both HIV and HPV are found to have reduced HPV clearance rates, as well as an increased risk of persistent HPV infection compared to women who do not have HIV or not living with the virus. People living with HIV have a significantly increased risk of developing cervical lesions, as they are more likely to have a persistent high-risk HPV infection. So they could have been infected with any one of the 14 high-risk genotypes. And studies have shown that high-risk HPV prevalence, high-risk HPV viral load, and cervical lesions among women who are HIV or living with HIV compared to those that are negative. So let's start looking at a few studies, right? So we'll start off with this study that was done in South Africa. The title of the study is here, and it's the high prevalence of HPV in unvaccinated adolescent girls in South Africa, particularly those that are living with HIV. So this study was published in, just last year, 2024. It was done in 4 provinces of South Africa, which is the Free State, Gauteng, Mpumalanga, and the Northwest. And their target group was adolescent girls and young women. So they stratified a very narrow age range between 17 and 18 years old, right? So when these girls consented to participate in the study, they took their questionnaire, their demographics, their health history, their clinical data, etc. They had to go undergo HIV counseling and testing, and they were instructed on how to collect the vaginal swab. So it was a self-collected vaginal swab for HPV testing, and they used one of the platforms that are quite often used, which is the Aniplex HPV platform. This platform is nice because it gives you every single genotype high risk separately. So it will tell you, it won't group the 16 and 18, it will tell you whether you have 16, whether you have 18, 66, etc., right? So that's how they tested the sample. So let's look at some data. Unfortunately, I don't have a, okay, yes, this will work as a pointer. So let's look at some data. So the bar graphs in the green are the women that were HIV negative, and the bar graphs in the red are the women that were living with HIV, right? So if we look at this, we could see that for both the high risk as well as the low risk types, there was a higher prevalence of the individual genotypes in the women that were living with HIV, all right? So it's a consistent figure that you're seeing, and the little error bars in the top and the asterisks denote that those were statistically significant. So they found a significant difference that if you are living with the virus, HIV, you have a higher likelihood of having tested positive for any one of these high risk and low risk HPV types, all right? So if they took it further and they wanted to see, were these women really at risk? They did further statistics, and they found that, let's look at the bold. They looked at the HIV negative woman as the reference category, and they looked at, if you were living with HIV, what was your risk of getting a high risk HPV infection? So women living with HIV had a 3-fold higher risk, which means you had a 3-fold higher chance of getting a high-risk HPV genotype, all right? Whether you lived in the Free State or you lived in the Northwest, that had nothing to do with you acquiring or having this infection. It was specifically having the HIV virus, all right? Your age as well didn't make a difference. Whether you were 18 years old or whether you were 17 years old, it didn't increase your risk. It's basically the virus. So this validates or reinforces hypotheses or suggestions that HIV increases your risk of getting HPV, all right? And we look at both studies, right? So evidence from laboratory, clinical, as well as epidemiological studies where they've tested a large number of samples, they support the hypothesis that STIs facilitate the spread of HIV, right? So they looked at chlamydia trachomatis, they look at HSV2 and Neisseria gonorrhea. These previously have been shown to increase the risk of HIV. So now we're starting with the bottom layer, right? Let's look at the bottom layer. So therefore, STIs are cofactors of HPV. Why? Because if STIs increase your risk for HIV and HIV increases your risk for HPV, your STIs are a cofactor, namely C. trichomatis gonorrhea as well as HSV2. And I'm going to show you studies where HSV2 has been a real big cofactor, right? So STIs such as chlamydia trachomatis, Neisseria gonorrhea, Trichomonas vaginalis have been associated with HPV infection and persistence, leading to delayed infection clearance and possible induction of precancerous lesions for cervical intraepithelial neoplasia, CIN1, 2, or 3. So the association of HPV infection with some of these STIs is due to chronic inflammation or immunosuppression, which promotes the susceptibility to and progression of the high-risk HPVs persistent infection. So there's a biological reason for this as well. Inflammatory markers are being upregulated. If you are immunosuppressed, you have a higher likelihood, right? So therefore, women living with HIV that are co-infected with any one or more of these STIs are at high risk of developing cervical cancer disease and invasive cervical cancer. So women harboring or having a history of chlamydia infections are less likely to clear HPV infection, and they are 2 times more likely to develop cervical cancer disease. Mycoplasma hominis, the genital mycoplasmas, Mycoplasma hominis and ureaplasma species are associated with an increased risk of HPV persistent infection and abnormal cervical cytology. So let's look at somewhere else in Africa, out of South Africa, Mozambique. So this study was done in non-pregnant women in Mozambique. They came seeking healthcare related to either gynecological issues or such as genital pain, genital ulcers, vaginal discharge, and for family planning, right? They collected cervical samples. Now these were clinician collected, unlike the other study, which was self-collected. These were clinician collected from 233 women, and they used different assays for the detection of HPV, and they also looked at detecting the STIs, all right? Also quite a fairly recent study published last year, right? So if you look at this, right, so the coding is basically all the STIs. Unfortunately, yeah, they didn't look at Ducray. They probably didn't have many women with symptoms. But remember I mentioned HSV. So if we look at this guy here, 0.5, it shows that it is HPV infection and HSV2 are associated, and it is significant. So in the women who had HSV2, a higher proportion, which is 11.1%, had HSV2 compared to women who were HPV negative, only 1.4% of them had HPV. So it's showing that there is a significant association between HPV and herpes simplex virus type 2. There's another study that was done in the Eastern Cape to show similar data. This study was done on a woman as well, aged 30 years and older, the little older cohort. They were going for cervical cancer screenings and for other reasons in the rural part of the Eastern Cape. The samples were collected and they were also tested for HPV using a different platform, and they tested them for specific STIs as well. A much older study done in 2021. So if we look at this data, keep in mind, HSV2 in the other data in Maputo is showing HSV2 is the problem. Similarly, here in South Africa, we are finding that women with HSV2 have a higher likelihood of developing high-risk HPV. So they are at a almost five-fold chance of getting HPV as well, and this is significant. If you have an HIV infection as well, you are 2 times likely to get HPV. So it's showing the significant association between the STIs, the viral STIs, and HPV. Then you may be asking yourself, but what about the other STIs? What are they doing? All right, so we'll talk about that. So this was a vaccine trial that was conducted in the Western Cape now. It was the efficacy of the HPV vaccine to reduce HIV infection. It was called the EVERY trial. It was conducted in younger women as well, between the ages of 16 to 24, a little wider age group. And these women were randomized to either received the 4-valent HPV vaccine or placebo. But remember, this was done within the confines of a clinical trial. It's not what's represented in the public sector. So when the women were if they consented and they were enrolled in the study, they were tested for HPV as well as for 5 STIs, including herpes in there as well. So if you look at the pie chart, I'll draw your attention. You can see my little arrow. Yes. So the co-infection between HPV and HSV2, now it's HSV2, right? Not HSV1, the cold sores, HSV2. So the co-infection rate is quite high, 26%, further validating how HPV and HSV2 are linked. So let's look at the science behind it, or the biology behind it. So HSV2 increases the odds of acquiring other STIs and is considered as a cofactor for HPV in the development of cervical cancer. Women positive for HSV2 and HIV infection were reported to have cervicovaginal inflammation and harbor a diversity of microbes. These viral STIs have been found as independent risk factors of cervical cancer disease. A case control study showed that women living with HIV had a significantly increased prevalence of abnormal cytology, which was 13% compared to women who were HIV negative, which was 5%. Similarly, the presence of HSV2 infection was 5-fold higher in women with cervical or CIN and squamous cell carcinoma compared to those with normal cervical cytology. Moreover, the co-infection of HPV and HSV2 was significantly associated with cervical cancer lesions and cervical cancer than healthy women, suggesting that this infection could be involved in the progression of cervical cancer. So we've looked at HSV2, we looked at HIV. We must be asking ourselves, well, what about the other STIs, that we've mentioned? Has anyone heard of bacterial vaginosis? Yes, BV. Although not a STI, it is a reproductive tract infection, and it is a polymicrobial syndrome, meaning that one bacterium is not responsible for the syndrome. There's different bacteria like Gardnerella, Atopobium, BV-associated bacteria. There's also Megaspira. It's a syndrome, right? It's a whole lot of these guys working together to cause the syndrome. So let's look at this study that was done by Caprisa. It was looking at high-risk HPV prevalence among South African women diagnosed with other STIs and BV. Published in 2023 using the Caprisa 083 cohort. The guys from Caprisa here, you all will be familiar with this cohort, right? So the study enrolled non-pregnant HIV negative women who were 18 years and older, and they were attending the clinic, the PHCs for sexual and reproductive care, right? They had collected their samples using a menstrual cup. So the cervicovaginal lavage sample was collected using a menstrual cup, and they tested them for the different HPV genotypes as well as for STIs, and they did microscopy to look for the presence of BV, diagnosed BV via Nugent scoring. So what did they find? They found that in the women, they stratified, they took all the women, they first tested them for HPV. They found that 83 women were HPV positive. Then they said, right, in this woman, let's look at how many of them had STIs, how many of them did not have STIs and BV, and if there's a significant association between STI and BV and HPV. And they found that 36% of the women who were HPV positive were also STI and BV positive. And this was significant because only 9% of the women that were HPV positive did not have an STI or BV, right? And the majority of the women, although they had low risk HPV, if you look at the high risk HPV, it was significantly associated with an STI or BV. And the p-value, the data is on the slide there, right? So they wanted to see, let's do further statistics and see if this was really the case. And when they did further statistics, they found that when you have BV alone, you are at increased risk of having, well, if you have HPV and BV alone, there's a relationship, right? If you have a co-infection. If you have an STI and BV together, you also have a HPV co-infection. So they found that the co-infection between BV and STIs and HPV was significant, right? So we're moving away from the HSV2 story now, right? So keep that in mind. And then in 2022, Prof. Sebotlane and myself, we worked with Dr. Kavitha Naidu, and we did the study at the Clinical Medicine Lab, where we looked at BV-associated bacteria as biomarkers for HPV risk and the progression of CIN, all right? So as I mentioned, that study investigated BV-specific bacteria and high-risk HPV. We tested using the Cepheid Gene Expert, which was the partial genotyping, 16, 18, and 45. And for this study, we did it retrospectively. So we took the samples that were stored in the freezer, and we decided to test them for the BV-associated bacteria to see if remnant samples could still give us data, right? And when we did this, we found that amongst the HPV positive women, that we found a high prevalence or significant association between BV-associated bacteria and A. vaginae in women that were HPV positive, all right? So you could see A. vaginae, BV-associated bacteria 1, BV-associated bacteria 3, and lactobacillus species, as well as Smithia. All these guys that are responsible for causing BV, the BV people would know what I'm talking about. They were significantly associated with being HPV positive. But then Kavita took it one further, and she's further stratified by women that had persistent HPV versus women that had HPV reinfection. And she found that if you had BVAB3, you also had a persistent HPV infection, or you were at risk of getting a persistent HPV infection, or B, being reinfected with HPV. So this study holistically showed that something like BV, which we don't even consider as an STI, is responsible for driving HPV as well. So BV has been previously associated with prevalent or new HPV infections and low-grade squamous intraepithelial cervical lesions. Studies have demonstrated that an optimal female genital tract environment is dominated by lactobacillus species, which are protective against HPV, whereas those with diverse microbiota have BV, more of a BV dysbiosis of the vaginal environment. So women with high relative abundances of Atypobium vaginae and Gardnerella vaginalis, which are the BV players, have been shown to increase the risk of acquiring new HPV infections and facilitating HPV persistence. It has been hypothesized that the mechanism behind increased HPV risk in women with BV may involve the disruption of the epithelial vaginal barrier, which Gardnerella is responsible for causing. So limited research has focused on understanding the link between BV and HPV infections and cervical and precancer. There's a research idea for someone wanting to do a PhD. A meta-analysis of 12 published studies involving 6,372 women aged between 13 to 69, really broad age range, found that prevalent BV was linked to uterine cervical HPV infection, and the odds of this was 1.4, but none of these 12 studies were even done in sub-Saharan Africa. Another niche for research to be done here, right? In 2 separate large cohort longitudinal studies, now remember nothing in SSA, BV was associated with persistent cervical HPV among women from Finland. But due to the high burden of BV, HPV, and cervical cancer in sub-Saharan Africa, investigating their potential relationship with the incidence and severity of CIN among women within our region is essential. There's a research idea. And that's where I end. Thank you.
Thank you, Professor. Any questions? Comment?
Okay.
Dr. Pandey?
So when I trained at the registrar years ago, we were told that in the public sector, we would treat an STI with, a cocktail of antibiotics.
Syndromic management. Yeah.
Too much to identify which organism. And we know that the dangerous organisms for infertility, tubal damage, and ectopic pregnancy, etc., which is all on the rise, anecdote from all our hospitals, is chlamydia and Neisseria gonorrhea, which is often asymptomatic. So are we at the same stage now where we cannot afford to actually do swabs and test for these organisms and just give that and we're not going to go from?
Well, we've been trying to, since 1999, this has been going on, right? Syndromic management. And the problem with that, apart from just, well, it was shown to be cheaper, but sometimes cheap is not always good, because what about the asymptomatic woman? We're missing out the asymptomatic woman that could be testing positive for HPV. They may not have a positive sample, but it could progress to that if they harbor the actual genotype, right, the high risk genotype. Then we are overtreating, and then we're wondering, why are we getting superbug for Neisseria gonorrhea? because we're overtreating. But the data is there. But there's still no implementation of test and treat for STIs. We're still going syndromic in the public health sector. Privately, yes, you will send your sample. You go to your GP, they'll send your sample to Lancet, or, you know, to those laboratories, UPL and stuff. But public sector, we haven't. Yes.
Yeah, I was just following up on what you said, and thanks for that very enough. And number, that's coming back to Dr. Pandey's question. It's not just a cost I think, and maybe you can advise. It's also what we have at our disposal to collect a proper sample. I'm not sure if I just take a normal swab.
No.
I send it to the lab, it tested for even these PPs. You know, you can't just take a normal sample, but take it in a special medium and blah, blah, blah. And I think there's a little bit of hurdles for us to test. And just coming back to us moving away from syndromic management versus targeted management. From I know that there's been a call to, so the people with the money have sent out the call to participate in that trials that compare syndromic versus targeted. And the jury is out any day as to whether they can invite any of the
Yeah, we've all applied.
Really look at what data does this is
Yeah. Okay. Yeah, sure. I'll start with your first comment about the sample. So to test for chlamydia and gonorrhea, we don't need a special sample because we're not going to culture. It's a urine. All we need to do is come in, pee in a cup, right? So we're talking about, let's talk about platforms, right? So right now, the WHO also advocated for the use of the expert instrument for the testing of TB. Remember, rifampicin-resistant tuberculosis, right? It's placed at the NHLS laboratory to test for TB. That exact same instrument with a different cartridge can test for chlamydia and gonorrhea from a urine sample. So if it's placed there at the facility, you've got the most expensive thing, which is the machine sitting there. It's a matter of just purchasing the testing kit, asking your participant, or sorry, your patient to basically urinate. You only need about 50 mils of urine, and send it up to the lab to be put on the expert instrument. We don't need anything fancy. Well, the world knows it's a problem, right? I mean, if they didn't realize it was a problem, they wouldn't put out all these Gates Foundation calls for us to do STI randomized controlled trials, right? And right now, the controlled trial is actually to show how testing for STIs can alleviate pelvic inflammatory disease, because that's a big issue, right? So we've got the resources, I think. It's just a matter, and it's such a simple thing. It's a urine sample, really. It's just a matter of policy moving forward with it. Okay. Yes. Yeah. Yes. Yes. Okay, so with the Maputo study, if you notice that they did look at stratification by age, right? But there was no significant association. It was only the HSV2 and the HIV that was driving the presence of the HPV and the precancerous lesions. Age wasn't a significant factor. Yeah, that's why the latest studies, remember the last one we did, it was broader, 13 to 69. Yeah, Kashira. Correct. Yes.
How far off are we from getting 20 testing and other
STIs. Okay. So if the syphilis test is a cassette test, right, with the finger prick. So we have evaluated other tests. Similarly, I know for my own research, I've evaluated tests for chlamydia and gonorrhea using the same strip method where you can get a result within 5 minutes, right? Unfortunately, they don't follow the WHO criteria. They may be affordable, but they're not sensitive and they're not specific. So we're not yet there with those strips. We still have to go to automated or molecular-based platforms. Yeah.
Thank you so much, Prof. Abba, for such a wonderful talk. My question is, I think it's more general, but I think we seem to be going towards saying that most of the survival temperatures are due to HPV 16. I think my question is, do we have any like recent studies that really assess like especially in our setting, because HPV and 16 and 18 are more like globally unfortunate genotypes.
Yes.
We have like any recent research that is being done to kind of like assess in our setting which genotypes are the most unfortunate. Because I'm saying this because according to the International Agency for Cancer Research, they have their own staging of the different HPV genotypes, and they normally like list out all 14 HPV genotypes in the first category, which means they are more oncogenic, or according to their research, most of the cervical cancer cases that they pick up are coming from all these 14 HPV genotypes.
Yes.
And if there are no studies, I think we need to go back there, especially because we are only distributing a bivalent vaccine that only targets 16 and 18, and most of the other genotypes, you are not protected from other genotypes. You are only vaccinated for these genotypes.
Yes. Excellent comment. So about 2 weeks ago, there was the KZN Doctors Coalition, Health Coalition, with a little conference. Yeah, it was a Saturday morning. Yes. So they asked me to present on molecular detection methods for HPV there. And then I spoke about a meta-analysis where they looked at the different testing platforms and how they basically identify the different genotypes. And they show that you may not only have 16 and 18, you could have another high risk that is not included in the for the vaccine coverage. Excellent question. But unfortunately, those studies, again, done out of SSA, Sub-Saharan Africa. So we desperately need the data. Now, what's happening? So what's happening here is it all depends on the platform that we are using. So if we are deciding to test with the expert machine, we're going to get the 16 and 18/45, and then the other high risk is going to be pooled. So it could be any other high risk. We don't know what is the driver behind it. So if when we are running our studies in South Africa, where we want to have an accumulation of this data to show, let's not only focus on the oncogenes, which is the 16 and the E6 and the E7, which are the 16 and 18 genotypes. We have to be clever in the platform that we choose so that we can get not partial genotyping, but individual genotyping. So if you're developing new studies, keep that at the back of your mind. Go for platforms that are going to give you more data.
Sorry, can I just, so this was many years ago. It was before I subspecialized. There was a study looking at HPV genotyping in South African women. Those were done in Gauteng province. It was done, well, now he's Professor van Aert. If you Google it, you can find those studies quite easily. And he looked at all these 14 high-risk subtypes. And while 16 was the highest subtype in our population, it was 52 that was the second highest. 18 came around number 5 in total. And he compared it to using the different type vaccines, which I think is your question. And his conclusion was that if you use the Cervarix vaccine, you're still going to prevent 70% of cervical cancer cases. But in order to achieve optimal coverage, he recommended that we go for Gardasil 9. And yes, 100% completely agree. But we need to also take into account finance. All right. Dr. Shangati spoke about the different prices of the vaccines. At the moment, it's not feasible to offer Gardasil 9. Until such time the prices drop, then yes, we can. But until we get to that point, between 70% of new cervical cancer cases is still better than 29. So we use what we have until we get more.
I was just going to say the latest, it is really interesting the subtyping and what we see in South Africa. I think Professor Dreyer, Greyer, and Professor Gordon plus the lady, what the hell is Danny. Those are the three names you can change, and I think Williamson is another one.
Oh, yeah,
There
Annalisa.
are people who have mapped out what we have in South Africa, the latest data, and I think we can find there. Yeah.
Yeah.
And also the type of people that what we see in when we subtype HPV and find a whole lot, you find a big bus of these including invasive disease, but when you get to cancer, it's really 16 and 18 So cancer being your ultimate is led by only 2, whereas everybody else is like, what you do, trying to make.
Okay. Thank you. For
Okay, thank you.
And thank you everyone for attending. It's really been a very informative session. I'd like to call Prof. Sebastiani to close the meeting.
If I can close from where I am, thank you everyone. As the Samara said that, and thank the Samara to all the speakers that have taken their time. We really appreciate that. I know that the clinicians go to a clinic and must have moved into the case and all of that. Please note that there's screening outside for the blood pressure, the blood sugar, for the PEPs are available as well, PEP smear screening. You heard the story from Dr. Maharaj about how safe it can get if we don't. If we think that it applies to someone else and not to us, that comes with everything. The only thing that you pay for is your mammogram and your vaccination, but all of that is available. Lunch is also available outside, and thanks to everyone that like make the women safe. Get a picture of it.
Just the 9.